one and all. We'll start with the next session. It is on collagen cross-linking, and we are going to cover basics to recent advances of collagen cross-linking, and mainly it is aimed at comprehensive ophthalmologists and postgraduates and also the fellows in cornea. And the first talk will be on what is collagen cross-linking. The speaker is Dr. Manisha Dwivedi. She is a consultant at Center for Sight at Lucknow, and she is going to talk on what is collagen cross-linking. Over to Dr. Manisha Dwivedi.
Good morning, everyone, and thank you, sir. My topic of presentation is what is cross-linking. So I will be covering basics in this 15 minutes presentation. So cross-linking is basically formation of covalent bonds between the lysine and hydroxylysine residues of two collagen molecules or microfibrils. It can be intermolecular, intramolecular. Also, there can be formation of covalent bonds between collagen molecules and extracellular matrix proteins. It improves the mechanical strength. Naturally, it occurs as a process of maturation in collagen fibers. It can also be induced by chemical catalyst, heat, pressure, and radiation. So cross-linking has two major pathways. One is enzymatic cross-linking that is mediated by enzyme lysyl oxidase, which is naturally present in the corneal stromal tissue. And another pathway is non-enzymatic, which is basically because of glycation of the lysine and hydroxylysine residues of collagen microfibrils. It happens in cases of aging and also pathologically in diabetes. So if we look at the basic concept of cross-linking, what happens is in presence of UVA light, riboflavin molecule excites itself into its singlet state, later on into the triplet state, and there are two photochemical reactions that take into place. Type 2 photochemical reaction is oxygen mediated, that leads to production of reactive oxygen species, and after that there is type 1 photochemical reaction, that is anaerobic pathway, that leads to generation of riboflavin free radicals. Ultimately, that leads to formation of covalent cross-links between collagen microfibrils, also between collagen microfibrils and proteoglycan molecules of extracellular matrix. So corneal cross-linking, starting from the experimental studies and how the Dresden protocol was established, I will cover the brief historical perspective here. So cross-linking already we can see physiologically in cases of blood clotting. It already well-established procedure in cases of polymer chemistry. It was used previously in production of filling materials in dentistry. Apart from that, also it was used in prosthetic heart valves to improve their biomechanical strength. In 1990s, there was an article published by Malik et al. On aging of human corneal stroma. They studied the structural and biomechanical changes of an aging cornea, and they found out that there is non-enzymatic glycation of collagen that leads to the cross-linking. It is a non-enzymatic pathway, and also there was age-related growth of collagen fibril diameter. There were few other studies that showed that these aging phenomena, they increase exponentially in diabetic patients. Further, Spohr et al. In 1998 published an in vitro study on induction of cross-link in corneal tissue. This was a study on porcine corneas. And they used variety of photosensitizer as well as various wavelengths of UVA light as well as visible spectrum to check which combination works the best for corneal cross-linking. And they demonstrated that mechanical stiffness of the cornea can artificially be increased. In this study, they used riboflavin 0.5% concentration in presence of UVA light wavelengths 254 as well as 370 nanometer and visible spectrum light. Later on, Wolensek et al. Published their findings on in vivo cross-linking in moderate to advanced keratoconus patients. and they used riboflavin 0.5% concentration in presence of 370 nanometer UV A light, and they found that progression of keratoconus was stopped in all cases, and regression with a reduction of maximal keratometry reading and refractive error was noted in up to 70% of treated eyes. So what are the components of cross-linking? So cross-linking is basically consisting of UVA light and a photosensitizer, which is riboflavin. And presence of oxygen is fundamental in this reaction. So UVA light spectrum we use of 370 nanometer. Why? Because the absorption peak of riboflavin, it coincides at 370 nanometer. Also, it is safe for endothelium. If we go for a shorter wavelength, that may cause cellular damages to the DNA. And if we use the longer wavelengths, that can be harmful for the underlying structures like endothelium and lens. So riboflavin is the preferred photosensitizer in cross-linking. We commonly use 0.1% riboflavin 5-phosphate with 20% dextran or HPMC, depending upon the corneal thickness. In cases of transepithelial cross-linking, which are many studies have been published, we use transepithelial dyes in combination with riboflavin 5-phosphate because to improve the epithelial permeability to riboflavin. So these, for example, benzalkonium chloride, topical anesthetic, trometamol, sodium EDTA, these are being combined with riboflavin to increase the permeability of corneal epithelium by weakening the tight junction barrier of the corneal epithelium. Another method is iontophoresis, which is nothing but basically application of low-grade electric current over the corneal stroma that leads to increased permeability of riboflavin to the cornea. Once we do the epithelial debridement and after that we soak the tissue with the riboflavin, we can actually see it clinically via the slit lamp that riboflavin actually diffuses into the corneal stroma. And after that, exposure of UVA radiation is being done for the cross-linking. So role of oxygen is very fundamental during this process as it leads to free radical formation that catalyzes the cross-linking between collagen fibers. Because of this reason, in cases of transepithelial cross-linking and in accelerated cross-linking protocols, because epithelial debridement, if not being done, that may lead to decrease in depth and strength of cross-linking. What happens after cross-linking procedure is done, there are few morphological changes that are noted in the corneal stroma. Most important reason for increasing the corneal stiffness and rigidity of the corneal tissue is increase in collagen microfibrillar diameter as well as decrease in interfibrillar spacing because of the cross-linking. Other factor which is noted is intense keratocyte apoptosis in the anterior stroma, which happens in the immediate post-operative period. And usually the keratocyte population starts repopulating after 2 to 3 month post-operative period, and it returns to the baseline level after 12 post-operative months. The damage to the keratocyte can be appreciated clinically by mild stromal haze that is in proportion with the level of stromal cell death. And also clinically we can appreciate it in the form of demarcation line, which forms between the irradiated and non-irradiated stroma. In cases of conventional cross-linking, it usually forms somewhere around the depth of 250 to 300 micron. And in cases of accelerated and transepithelial protocols, demarcation line is usually somewhere around 150 micron depth. What are the indications of cross-linking? So it can be basically divided into ectatic and non-ectatic reasons. So in ectasia, it can be primary, जैसे कि keratoconus or pellucid marginal degeneration. Secondary, it can be post-LASIK ectasia. Other indications are bacterial ulcers, corneal melt, and corneal edema. So once there is keratoconus patients, how to proceed in such situations? Most important factors are corneal thickness. In cases where corneal thickness is 400 micron or above, we can proceed with isoosmolar cross-linking. But if the corneal thickness is less than 400 micron, we can proceed for hypoosmolar cross-linking, but with caution. Second most important factor on the timing of cross-linking is age. So In cases of adult patients, documenting progression is required because as we know that cross-linking is being done to halt the progression of keratoconus, it is not required for already stabilized cases. In cases of children, because it has been well established that progression happens rapidly, there is no need to document the progression. Only in cases of doubtful cases, we may do the frequent follow-ups. Otherwise, at first visit, cross-linking can be done in cases of pediatric population. As younger the child is, higher the chances of cross-linking failure, so they might require repetition of the cross-linking in future. Now, how to define keratoconus progression? There was a study published, Global Consensus on Keratoconus and Ectatic Diseases in 2015 by Gomes et al. And they pointed out few points on steepening of anterior corneal surface, steepening of posterior corneal surface, thinning or increase in the rate of corneal thickness change from periphery to the thinnest point. There were no quantitative data as it cannot be extrapolated generally, because there are various machines available based on Schimflug or OCT-based devices, and they have their own indices, so the data cannot be extrapolated in general. Only recommendation here is that whenever we diagnose keratoconus based on any Schimflug-based device or OCT-based device, the diagnosis and further follow-ups should be done by the same machine, and they have their own keratoconus screening indices, and progression can be decided based on changes in those screening indices. For example, in cases of Pentacam, we have BAD-D. In cases of Cirrus, we have keratoconus screening indices where we evaluate KVF, KVB, and SIF, SIB, and also higher order aberrations. After establishment of Dresden Protocol, there were various attempts on optimizing the outcomes and minimizing the side effects. There were accelerated cross-linking by varying the treatment time based on Bunsen and Roscoe law of reciprocity. Other than that, there are transepithelial cross-linking to minimize the side effects related to epithelial debridement. There was customized cross-linking where we do the graded cross-linking, which is localized on the cone area. There is also cross-linking can be combined with PRK and PTK for refractive correction. It can be combined with ICRS, and there is PAC cross-linking for infective keratitis, particularly bacterial ulcers. There are some contraindications of cross-linking. For example, pregnancy and breastfeeding patients, prior herpetic infections, active ocular inflammation, severe central or paracentral corneal scars, autoimmune disorders, poor epithelial wound healing, as in cases of neurotropic keratitis. Corneal thickness less than 400 micron was initially a contraindication, which is now a relative contraindication. We can proceed with hypoosmolar cross-linking, but we have to be cautious, avoiding the endothelial cell damage. So the next presentation will be done by Dr. Ankit Devkar about the Dresden Protocol. Over to you, Dr. Ankit.
So, very good morning to everyone. At the outset, I want to thank AIOC Scientific Committee and Dr. Malik sir for the opportunity. So today, my presentation will be on corneal collagen cross-linking and how it is performed, regarding the basics and how to proceed with it. So now, as we are clear about the indications of cross-linking by my previous speaker, we also need to document the data correctly whenever the patient presents to us in the OPD. It's important to document refraction, uncorrected and best corrected visual acuity, topography, and with a good acquisition quality and a central column thickness. This is important because, as we all know, that keratoconus is a progressive corneal ectasia, and to document the progression, the initial capture of the data is very important, which would help to determine the progression and help in deciding whether to go for a cross-linking or not. Now, the various clinical considerations that we need to keep in mind are age, that is patient presenting in first and second decade of life. We need to go for cross-linking as the patient is being diagnosed. In the third decade, we can wait for progression to happen and then document the progression, and then maybe we can go for cross-linking. We should also look clinically for associated allergies any active VKC or atopic allergy, associated syndromes like collagen vascular diseases or Down syndromes, and associated autoimmune history, like a patient with an autoimmune history is better contraindicated for cross-linking. Special considerations like pregnancy and lactation, we avoid cross-linking in that stage. And also presence of pre-existing corneal scarring and a history of prior corneal surgery, we need to go and just customize the treatment accordingly. Most important, as we all know that the patients in this age group, in which the keratoconus presents, are usually in the economically productive age group, and the most important thing for them is counseling. And there might be children who would be accompanying with their parents, and the counseling plays a vital role in deciding and making sure that what are we going to do with the cross-linking and how the cross-linking is supposed to proceed. So the patient should be very clear about the aim of cross-linking, that it's being done to strengthen the cornea and not to improve vision, or not to, sometimes the patient asks that whether I would be free of spectacles, something like that. So we should be very clear that it's not going to be like that. We should be clear about the expectations, of the procedure. We should also be clear about, the patient should also be clear about the course of recovery. How long is it going to take for the person to resume his day-to-day activities? And also the most important for which the patient has come to you is visual rehabilitation. So the patient should be clear that when are you going to give contact lenses or RGP or glasses, or proceed for eye seal in such patients. So coming to pre-op preparation, it's important to prepare the patient a day prior. Instilling antibiotic drops a day prior, 0.5% moxifloxacin 3 to 4 times a day is sufficient enough. Asking the patient to have a head bath, because the next 5 days he's not supposed to have, because he will be having contact lens, and that there might be chance of extrusion of contact lens. Avoid eye makeup on the day of procedure, and avoid use of any contact lenses on the day of procedure. So this is a C3R machine prototype, and as we can see that this is a display console of the machine, and this is the light emitting, UV emitting arm of the machine. It has got a foot pedal, so that you can adjust this UV emitting arm to focus it on the cornea. As in your right, we can see that the parameters which shows is a treatment power, the power at which we want to deliver UVA. The amount of time for which we want to irradiate the cornea, it may be varying depending on the protocol, what we are going for, and the total amount of energy that we aim to deliver to that particular cornea. Usually it is 5.4 joules per centimeter square according to Dresden protocol. Now here is a short video just to demonstrate that how do we adjust various parameters before starting before taking a patient for cross-linking. So this is a minutes through which we can adjust the minutes, and according to protocol we can adjust the power according to protocol. Now the machine also has got this UVA emitting arm, and it has got 2 red dots, and these 2 red dots need to coincide, and that is the endpoint of the focus of the UVA over the cornea. So we can move this UV emitting arm up and down with the help of the pedal, and this makes the endpoint at which we should irradiate the cornea with UVA. Now coming to the Dresden protocol, Gregor Wallenstein and Sperl in 1998 proposed a protocol in which 23 eyes of 22 patients were cross-linked at University of Dresden, and it is a AP-off protocol in which there are 3 stages: epithelium debridement, followed by soaking, and followed by irradiation. The most important thing we need to understand that cross-linking is a sterile procedure, and painting and draping plays a vital role in it. Lashes coming in the view of in the surgical field can be a nidus for infection, and also if there are more lashes, it might hinder the cross-linking as well. The procedure is performed under topical anesthesia. Now coming to the epithelial debridement, there are two ways in which epithelium can be debrided. Either it can be alcohol assisted, or it can be mechanical debridement. Now this is a short video of how alcohol-assisted debridement, how to perform a alcohol-assisted debridement. Absolute alcohol can be poured in this 9 mm well, and we have to wait for 30 seconds, and post that we can use Merocil to sponge to absorb the excess of absolute alcohol, and we give a thorough wash of 10 cc saline, and then use a dry Merocil sponge to just peel off the surface epithelium. It comes out mostly in toto, and gives a very good exposure of underlying stroma. Now, other option of mechanical debridement is epithelial debridement is a mechanical way. So the most commonly used instruments are either Tukes knife or a hockey knife for epithelial debridement. And this is a short video which shows how we can debride it in a effective manner. So we can use a blunt refine or a 9 mm Corneal template to create a mark, and this mark can be adjusted according to according where you have got a cone, and maybe you can recenter it inferiorly or superiorly, how you want to proceed. Then we have to disrupt the peripheral epithelium, and then can keep proceeding further ahead. The care is taken that at all time your spatula is striking at a 45 to 60 degree, not 90 degree exactly with the stroma. Otherwise, it can cause damage to the bowmans, as the bowmans in keratoconus patients is quite thick and is quite thin and fragmented. And if it is injured, then it can lead to a underlying stromal scarring as well, and and irregular astigmatism as well. So now we can flush with a saline and just scrape the remaining stuck epithelial cells over the cornea to get a good exposure of the underlying stroma. Now coming to the soaking phase, in this we soak the cornea for 30 minutes, and we put riboflavin 0.1% every 3 minutes for 30 minutes, so that the riboflavin can percolate inside in the stroma. And riboflavin, as we know, acts as a photosensitizer and increases the UV absorption by the cornea. After this phase comes the irradiation phase. Now during irradiation phase, we have to focus this UV arm over the cornea, and this is a short video in which we can see that the two red dots are being focused at the corneal plane, which marks the endpoint of UVA focus. And now we can start with the UVA irradiation following that. So irradiation of the power of in resident, the power of 3 milliwatt per centimeter square for 30 minutes is delivered, and the UVA source is 370 nanometer. The total energy delivered is 5.4 joules per centimeter, and in between we need to instill riboflavin intermittently every 3 minutes to keep the to keep the cross-linking on, and also we need to wet the cornea with BSS to avoid drying. So at the end of procedure, flush the surface with good amount of BSS. Use bud to absorb any extra amount of riboflavin. Put antibiotic drops, and place a bandage contact lens, which would help to reepithelize the cornea in the further post-op management. So now the post-op management of cross-linking has got 3 prongs. The first is pain relief, second is inflammation control, and the third is reepithelialization. So pain can be, to control the pain, any painkillers, paracetamol or a combination of paracetamol with aceclofenac can be given to the patients. Inflammation need to be controlled using a topical antibiotic and a steroid combination. Usually a surface steroid is sufficient enough, like a loteprednisolone with a combination of tobramycin 4 to 5 times a day in the initial week is sufficient for controlling the surface inflammation. To reepithelize the cornea, we need to give copious lubricants, either in the form of either containing 0.5 CMC or sodium hyaluronate based lubricants. Thus, the take-home message is to capture the data properly at the initial stage when the patient presents to the OPD, adequate counseling to elevate the anxiety of the patient regarding C3R and its complications, ruling out other contraindications, and taking care of sterility are the key for optimal outcome in C3R. Thank you. If anyone has any questions, meanwhile the presenter is being getting ready, we can go for that. So next I want to, I would, yeah, yeah, please, sir.
It takes away a lot of doubts because
Yeah.
you presented very well. Can you recommend any book which we can purchase to, because you have to reinforce yourself before you start doing this procedure? Any good textbook you would recommend for C3Rs? Keratoconus?
Recent updates on corneal cross-linking. There is a book I'll personally let you know. It's a Springer publication. So I'll just let you know about that. And it's a good, excellent book starting from the basics and covering the recent advances as well. So I think that would be.
What's the name of the book?
Recent Advances in Cross-Linking.
Thank you so much.
Yeah, thank you. So next I would like to introduce my next speaker, Dr. Anand Bala Subramaniam. He's a senior consultant at Shankara Eye Hospital, Bangalore, and taking care of cornea department over there. Next to you, sir.
Good morning, everybody. At the outset, I'd like to thank the AIOs as well as Dr. Malik for giving me an opportunity. Now, after these two talks, I would be playing the devil here by talking about complications of cross-linking. I'm just going to skip all these slides because all this has already been seen, shown. Now, we have already known that from its inception in 2003 onwards, for the past 20 years, it has transformed and it has gone through a lot of changes and has now become the global standard of care for treating various ectatic conditions. It is safe for children as well as adults, but still there can be a certain list of complications and unexpected response following C3R. Now, you can have a direct complication because of the incorrect technique or the wrong patient inclusion, or it can lead to indirect or secondary complications, secondary to the BCL that we use, the patient poor hygiene, and any undiagnosed ocular surface disease that has been there prior to the C3R. Now, it can also be because of the improper UVA exposure, because of the altered wound healing response, and because of epithelial removal, changes in the epithelial removal following the cross-linking. Now, it can be, the complication can be early when it is within 3 months after cross-linking, or it can be late after 3 months of cross-linking. Now, the list includes, in the early, it includes incomplete or delayed epithelial healing. They can be sterile infiltrates, both peripheral as well as central. You can have infectious keratitis, mainly reactivation of the viral infection or bacterial. There can be corneal edema or endothelial dysfunction, or even very rarely corneal melt. The late complications include biomechanical failure in the form of excessive corneal flattening, or vision impairment in the form of late onset corneal haze with scarring. But yeah. So the first one, the delayed epithelial healing. Now, as we all know, it is a very critical step because it helps in the penetration of the riboflavin or the epi-off technique. There are transepithelial cross-linking also being done to avoid this step, but efficacy-wise, studies have shown that there is a marked difference in the efficacy between the two. Normally, the epithelium heals within 3 to 5 days. If it doesn't heal within 5 days, then it is a delayed epithelial healing. Now, the reasons being, it can be because of the chemokines and the cytokines which are released from the epithelial cells, which are pro-inflammatory, which prevents the epithelialization. It can also be related to the BCL mismatch between the corneal curvature and the BCL. as we all know, the BCL comes only with 2-3 standard fits. So if in a very steep cornea, there might be a mismatch, and that can continuously abrade the epithelium at the steepest point. The use of NSAIDs and steroids also can result in delayed healing because of the MMP release. Very rarely there can be a differential limbal stem cell damage, especially in the superior and inferior. Very few studies have shown that there is a very basic impact on the limbal stem cells following the C3R. So patients who have undergone C3R should be carefully observed till the epithelium is completely healed, because it can predispose to infectious keratitis. Now, coming to steroid infiltrates, it has been reported up to 7.6% of the cases. It normally comes between 24 to 48 hours, and it is mostly in the periphery as compared to the center. Though center also it can come. That is because of the mediated immunity to the staphylococcal antigen from the ocular surface and the lid margin, which can be deposited at high concentration in static pooling areas, especially around the BCL in the periphery. Patients who have not been treated well prior to the, especially VKC patients have not been treated well before the cross-linking, advanced keratoconus, patients with blepharitis and thin corneas are predisposed to steroid infiltrates. If it occurs, we have to give high-dose topical steroids based depending on the stage or the severity of the infiltrates. And if not treated properly, it can lead to peripheral thinning and in very rarely perforation. So it is very important to refrain from leaving heaped up epithelium, especially at the margin, before placing the BCL. Now coming to infectious keratitis, the presence of epithelial defect, use of bandage contact lens, and topical steroids in the immediate post-op period are risk factors. The overall incidence is very, very less, because CXL nowadays is being used even for infectious keratitis. And it is, and there's a study by Tamilis who clearly showed that the infections tripled when the patients were put on BCL and topical steroids in the immediate post-operative. Now, this normally occurs between 2 to 6 days after the procedure. Studies have shown that 50% of them are bacterial, out of which 30% are gram-positive and gram-negative. Very rarely, there can be a reactivation of the previous viral infection because of the UVA radiation, post-op use of steroids, and because of the release of inflammatory cytokine. So the picture on top was my own patient who had a very severe infection. Scraping had shown gram-positive cocci. We treated with vancomycin and moxifloxacin, and subsequently after 3 to 4 months, it completely scarred. The one picture below is a reactivation of the previous viral infection, where we can see dendritic pattern. Now, there are also been reported CTK following cross-linking, which is very similar to that seen in LASIK, where there is a central or a paracentral non-inflammatory opacity. There can be presence of striae and flattening, which can cause a hyperopic shift. Now, the reason is unknown, but they have postulated to be because of the surgical glove components, secretions from the memobrane gland, or it can even be because of the marcopen or the povidone-iodine. Very rarely, there can be stromal loss in CTK because of the keratocystic apoptosis. Now, endothelial related, it is very, very less in literature. The permissible, irradiation at the endothelium is around 0.35 milliwatt per centimeter square, but because of the good absorptive property of the riboflavin, it is only 0.18, which is very, very safe for the endothelium, but still it can occur, and normally it presents during the first 1 week post-operatively. And Gokhale in his study has shown very clearly that in the immediate post-op, there is as much as 40% lower endothelial cells as compared to the fellow unoperated eye. Now, it can be because of the riboflavin solution, or it can be because of the improper calibration on the positioning of the cross-link device, as it was very clearly mentioned by Dr. Ankit in the previous talk. It can lead to epithelial and stromal edema, which is diffuse, accompanied by DM folds, and in very, very severe cases, it can even lead to decompensation. Coming to corneal haze can be early onset and late onset. The early onset mild haze is generally seen in almost all the patients, and it is also considered as a surrogate marker for the efficacy of the cross-linking. Now, very rarely beyond grade 2, it's around 9.3%. It is very important to differentiate between the haze of PRK and C3R, wherein in PRK it is much more superficial, whereas in C3R it is slightly more deeper, somewhere in the 200 to 300 micron range. The reason being because of the repopulation of the activated keratinocytes and the reorganization of the collagen fibers, which can affect the light backscatter and the corneal transparency. Now, most of the times it is self-limiting, which peaks at 1 month, and then there's a gradual reduction between 3 to 6 months, and 6 months, most of the times after 6 months it clears off. In very symptomatic cases, we can give an intense course of topical steroids. Now, the late onset haze is anywhere between 8.6 to 12%. The risk factors include advanced keratoconus, Vogt striae, then keratometry more than 70 diopters, and a thin cornea less than 420. Very rarely, in very advanced haze, it can cause a reduction in the BCVA and increase in the hyaloid aberrations. Now, coming to the biomechanical failure, one diopter flattening is something that all of us desire following the C3R procedure, and we know for sure that it improves the best corrected visual acuity as it flattens the cone, and sometimes it also helps in the contact lens fit also. But what happens is sometimes is because of reasons unknown, this flattening can progress where there can be a hyperopic shift, and there can be visual deterioration. Now, various studies have shown that corneal flattening greater than 5 diopter is considered as a progressive flattening. Now, several studies have shown that a preoperative Kmax more than 55 diopters is considered as a risk factor for corneal flattening more than 2 diopters within the first year of surgery. The other risk factors include age and stage. So younger the age, it is postulated that more the flattening can occur, and also the stage. So more advanced the stage, more the flattening that can occur. They also have shown that patients who underwent a cross-linking procedure, over time also, they can be a progressive flattening as late as 12 years post-op also. Now, just 2 pictures depicting the pre-op picture as well as the progressive flattening that is seen over time. Now, coming to keratoconus progression, which is the last, the progression can occur in around 0.08 to 33% of the patients. It is more seen in the epion as compared to the transepithelial, and it is defined as a Kmax increase of more than 1 diopter within 1 year, or a loss of BCA of at least 2 lines. Now, Collar in his studies has shown that a patient who has a pre-op Kmax 58 would reduce the incidence of failure in around 1/3 of the patients. Habitual eye rubbing as well as patients who are predisposed to allergy in the form of atopic patients and hormonal imbalances are other risk factors. Now, extreme corneal thinning and eccentrically located cone has also become additional risk factor for progression. It is also very important to differentiate a pseudo-progression, especially in patients who are contact lens warpage and epitel hyperplasia. So if a patient has undergone a cross-linking and is regularly wearing contact lenses, especially RGPs or rose-scale lenses, it has to be stopped 1 week prior or 2 weeks prior before you do a repeat topography. And if you are suspecting epitel hyperplasia, then we have to do an epitel mapping or a advanced ASOCT mapping. This is just a picture showing you the increase in the keratometry in the topography. To conclude, complications from cross-linking can occur and warrant caution when considering treatment for all individuals with proper patient selection. Early and prompt diagnosis and treatment can prevent vision-threatening sequelae, and it is very important to have a follow-up of these patients because they can be late complications as much as 10 years post-C3R. So please don't take this procedure lightly because every procedure has its own set of complications which you have to keep in mind. Thank you.
Thank you, Dr. Anand. That was a wonderful talk. Any questions for Dr. Anand? Any doubts or any questions?
Okay, now I would next invite our chief instructor, Dr. Mallikarjun, to give a very important talk on the recent advances of cross-linking, which is the happening thing right now. So over to you, Malik sir.
Um, uh, Dr. Anand, I have one question for you. You had any melts or something after C3R, Corneal melts or using con? Okay. Sometimes it happens because if you use NACIDs, NACIDs actually they are not advocated in following C3R. There are some rare reports that sometimes the corneal melt can happen. So you should avoid NACIDs immediate post-operative to manage the pain and all. So good morning on all. I am going to talk on recent advances in collagen cross-linking. Recently, there have been a lot of advancements in cross-linking, like accelerated cross-linking, pulse cross-linking, transepithelial cross-linking, C3R in thin cornea, C3R with low vision corrections, and also PAC-C scale for management of infectious keratitis. The main problem with Dresden protocol is time. So it will take almost 30 minutes to finish the procedure. Sometimes what happens, these patients will be very uncomfortable. And so I have seen in my cases, in between, they sometimes get up and they bring their hands and touch the console and all. That is the main concern because a drape is put, they are looking at the light and almost 30 minutes they have to look at the light. So this is the concern with Dresden protocol. To overcome this limitation, the accelerated C3 has been proposed, and it is based on Bunsen and Roscoe law of reciprocity. So what it says is effect of photochemical reaction is directly proportional to the total irradiation dose. Suppose there is high irradiation for a shorter period and lower irradiation for a longer period, the effect will be same. So whatever effect we get in Dresden protocol, same effect we can get in a accelerated protocol. See, in a standard protocol, our aim is to get a total fluence of 5.4 millijoule per centimeter square. The same can be achieved by altering the time and energy. So if you irradiate for 3 minutes of a 30 energy, 5 minutes of 18 energy, or 10 minutes for 9 energy, we'll get the same fluence. So the cross-linking, whatever the irradiation we do, will be same. So that is taken advantage in a accelerated cross-linking. So whether these accelerated cross-linkings are as effective of Dresden protocol. So this is the study. They have done a meta-analysis. This is published in Ophthalmologists in 2018. They compared the standard C3R with the accelerated C3R. And they included around 22 studies and 1,158 eyes were included. 577 they underwent a standard protocol and 581 underwent accelerated protocol, almost same numbers. What they found out was in a standard protocol, there was little bit more depth in demarcation line. And in accelerated protocol, it was better in thinner corneas. And both the procedures provided equal results in strengthening of the cornea. So the purpose was achieved in both the protocols. Now there are so many accelerated protocols. Which one you have to choose? So when the accelerated protocols came into practice, many people started doing all type of protocols. 3 minutes acha hai. So 3 minutes they used to do immediate. So 3 minutes patient will be happy and they used to do 3 minutes and send off. So they compared when the studies started coming, the 30 minutes redirection for of 9 energy, it outperformed other all accelerated protocols in terms of corneal stability, improvement in visual acuity, keratometric values on corneal stability. Most of the surgeons, they prefer this protocol for accelerated protocol. As earlier Dr. Manisha told, to have a very good cross-linking, we should have 3 important components. One is ultraviolet A rays, riboflavin, and very important is oxygen. See, in accelerated protocol, what happens? The rays will be coming continuously and in a very fast. So what happens? At the level of cornea, the oxygen concentration will be reduced. So that would lead to the ineffective cross-linking. To overcome this, the pulse C3R has been proposed. So what happens in here, the irradiation won't come in a single beam. So it will come in a pulse way. So like we get in a pulsed phaco, no? Like that, it will come in a 1 second on, 1 second off. So in the off time, there will be more availability of oxygen. In that way, the C3R also has been, can be done, and also there will be availability of oxygen. So this shows more cross-linking. This is the study to compare the pulse C3R with a normal accelerated C3R. So what they found out, the demarcation line was better in pulse C3R than in a accelerated protocol. Demarcation line is the which we always look for after C3R. That is the line which differentiates between the cross-link cornea to the normal cornea. It has to be at least 150 to 200 to tell that cross-linking has been done effectively. And here, the pulse C3R showed more depth of demarcation line. Although this pulse cross-linking showing promising results, we exactly don't know how much pulse to adjust. Whether 1 second on, 1 second off, or whether we should do a 2 second on and 1 second on. Then it needs to be evaluated, and more studies are required. And in a standard C3R, what you do is we remove the epithelium. So what happens? This will lead to the risk for infection and post-operative discomfort, and it goes to the less safety profile, because we usually do it in younger patients. Sometimes in pediatric patients, we scrape the epithelium and put them in bandage contact lens. So there are chances of infection, as told by Dr. Anand. And there can also be enhanced riboflavin penetration in the cornea, which can lead to other damages in the endothelium or lens. So to overcome this, whether we can do C3R in an intact epithelium. The corneal epithelium is stratified with the tight junctions. So that leads to barrier for riboflavin absorption. So whether we can loosen these junctions, that can be achieved with some drugs like EDTA, BAC, or Tramadol. So when you apply it before the C3R, this loosens the epithelial cells, so makes the riboflavin to enter into the stroma more easily. So we can do a C3R actually in a intact epithelium. Another method is iontophoresis. So here we are not going to do any epithelial scraping and not going to do any chemicals here. This is a device which is kept on the eye, and there are some electrodes which are kept on the eyebrow and also the lids. It will create some electrical gradient, because when it creates an electric gradient, the negatively charged and hydrophilic riboflavin moves across the lipophilic corneal epithelium. So it goes inside the intact epithelium and soak the stroma. So thereby you can do the C3R. But it needs all these machines, and it is undergoing all the investigations, and you have to receive a standard device to do iontophoresis. See, in Dresden protocol, they mandated 400 microns is the minimum corneal thickness is required for a C3R. So what about the corneas which have the thickness of 460, 470, 490, 360, 380 or 390, whether we can do a C3R for them? Yes, we can do a C3R to them. by utilizing these methods. That is using a hypoosmolar C3R. So it contains a riboflavin with sodium chloride. When you apply this, because of sodium chloride, the stroma will swell up. It almost becomes a double. So then you apply the, is it as it we are, you are increase the thickness of the cornea. Then safely we can do the C3R. And this is the most commonly performed C3R for thin corneas. There are other methods also we can do in a thin corneas, like customized epithelial debridement. Here, what we do is, we do the epithelium scraping and leave an island of epithelium on the thinned area of the cornea, where there is cone is there, and do a C3R. So that the thinnest area is where the riboflavin can enter more into the cornea and cause other adverse effects. So that is left behind, and then C3R. And we also can use a lenticule. You do a smile procedure in myopic smile procedure, and lenticule is placed on the corneal apex, and then the riboflavin is applied. So what happens? It is a natural cornea. So what happens? It will augment the corneal stroma. It will augment the corneal thickness. So then we can do a C3R. In the same way, we can also use riboflavin soaked soft contact lenses, which can be kept on the cornea, and the C3R can be done. Altogether, what is here? We are trying to increase the corneal thickness and doing the C3R to have a safer effect. For the refractive surgeon, the post-operative ectasia is still an enigma. Even if you do a lot of investigation, pre-operative investigations, use a lot of gadgets, apply so many formulas are available now, there is a risk score is there. Even though in some cases we get a post-operative ectasia. So in such cases, we can combine this C3R, like in high refractive errors, doubtful topographies, and in thin corneas. What we do is, we do a refractive procedure, and same time we do a C3R. So it can be combined with LASIK, it can be combined with PRK, or it can be combined with SMILE. These are called as extra procedures. So you have to remember, these are called extra. PRK extra, LASIK extra, all SMILE extra. Extra is what? Extra is cross-linking. So basically, you correct the refractive error by laser wave correction, then freeze that cornea by doing C3R, so that it won't modify afterwards. This is a study published in AIOC, Indian study in 2020. They included 1,512 eyes which were all high risk for post-operative ectasia, and they did all PRK extra, LASIK extra, SMILE extra, depending on the corneal thickness and topography. What they found out was, refractive surgery and simultaneous C3R is generally safe and delivers comparable results in terms of visual and refractive outcome than refractive surgery alone. So doubtful cases, we can combine C3R. And this term you have to remember, C3R plus. C3R extra is different and C3R plus is different. Here basically this was a term coined by Dr. Camionis in 2011, and basically what we do, we treat the keratoconus with C3R and then refractive error with other procedure. So most commonly performed is PRK with C3R. It has to be done topo-guided, and there are some limitations for this procedure. We cannot go beyond 50 microns of depth of ablation, and post-operative corneal thickness should be 400. So if the post-operative corneal thickness reduces than the 400 after refractive surgery, these patients are not fit for the PRK extra. And here the aim is to correct the corneal irregularity, not to correct full refractive error. So when you correct the irregularity of the cornea, post-operatively they accept the contact lens or spectacles better because it reduces some amount of aberrations also and cornea is regular. And we can also use intracorneal rig segments with C3R. It can be done in same sitting. First ICRS implantation and C3R. It can be done in epithelial off, epithelial on. Here riboflavin can be introduced through the corneal channels. We make a corneal channels for the introduction of ring segments. The same way, in the same channels we put the riboflavin, and we can also create the intrastromal pockets and do the C3R. Phakic IOL with C3R. First you do a C3R, stabilize the cornea, and after 1 year see whether the cornea is stabilized or not. Then we can go ahead with the implantation of phakic IOLs like ICL, IPCL, all those things. The drawback here is corneal irregularities are not corrected. So there will be some amount of aberration depending on the keratoconus. And only the spectacle power is corrected, not the whole, all the aberrations are there. And if the cylinder is high, that is a limiting factor because the phakic IOLs maximum cylindrical power we get is 6 diopters. So the cylindrical power is more than 6 diopters, so it may not be applicable. And this can also be, C3R can also be used for infectious keratitis because when it is photoactivated, there will be oxygen species which subsequently act on the microbes. So this has shown us some promising results. This is one study where recently published. They did C3R for infectious keratitis. It can be alternative to antimicrobial drugs. So you can do it as a first line in treatment. The only drawback here is we cannot do it a very well established keratoconus. Infectious keratitis. It can be done in an early infectious keratitis or a moderate case of infectious keratitis. This is the one example where the C3R alone has been done. In a first case, there is infectious keratitis, and after 7 days, it starts healing, and at the end of 28 days, it completely healed. And the second image also shows the infectious keratitis. After C3R, it's completely healed. So here, they have done only the C3R for the infectious keratitis, which is mild case. Thank you for patience hearing. So if there are any questions to any speakers, because we have another 10 minutes, we can take the question. Yes.
Sir, for plus procedure, how long do you have to wait between the procedures? For plus CXL, how long do you have to wait after doing CXL for?
We have to be sure if you are doing plus the phakic IOL, at least 1 year we have to wait.
For the PRK, trans PRK?
See, PRK can be combined with C3R because only thing is the limiting factor is we can ablate only 50 microns. But if you do C3R now and do a PRK later, what happens? That is not advisable. Why means whatever the cross-linking has been done, that cornea will be ablated later.
Okay. Yeah.
So the cross-linking effect will come down.
Okay, sir. So if we have a 440 micron thick cornea and we are ablating 50 microns, so the effective residual thickness will be 390. So is it advisable to do C3R for that patient with the PRK?
The 430 depends on the refractive error. So the post-operatively the corneal thickness has to be 400 microns along with the cornea, along with the epithelium.
Along with the epithelium.
So it depends. If it is the 1 or 2 cylinders, it can be done. So it will ablate around 15 to 20 microns. So there we can do a PRK extra. But if it suppose the refractive error is 3 or more, so this may not be safe.
So for the Athens protocol and all, in Athens protocol and all, you can ablate, I mean like you can correct half of the refractive error, so that,
That can be done. That can be
Okay.
done. So sometimes what some surgeons they don't correct the refractive error. They just regularize the cornea.
and the higher order aberrations, right?
Later you give a contact lens
Okay.
or spectacle, depending on what acceptance.
So what you're saying is for extra procedures, 50 microns of ablation is the maximum we can do.
Yeah, 50
And
is the
residual should
safest,
be
but nowadays
400.
they are going up to 70, 80 also they are ablating. But
Okay.
there have not been any studies where it is totally validated. It is
Okay.
not totally validated. Still, but I prefer to do only 50 microns. I don't go beyond. Some people they are doing even 100 microns because it looks very easy, very advantageous to patient now. We don't know what will happen later after 2 years, 3 years. We don't know what will happen. But 50 microns is it has been validated
Safe.
and many surgeons are doing and results are also good and it has got a long follow-up also.
Sir, I have one more doubt. For extra procedure, is there any role for hypersmolar riboflavin to increase the thickness if it is below 400? Do you
Yeah.
have any experience with that?
Yes, yes.
For the extra procedure.
Yes, because it's
Extra
a thin.
also you can
Yes,
do.
because it's the thin you can do it.
Okay. And so one more question. Why is it contraindicated in lactating mothers?
Contact lens?
No, why is it contraindicated in lactating mothers? Pregnancy I can understand, but why contraindication in lactating mothers? Because I recently, CXL, contraindication in lactating mothers.
Contraindication for? Because there will be hormonal changes in the mother. So these estrogens levels and all known to cause modulate the cornea temporarily, not permanently. During the lactation and during the pregnancy, there can be change in the corneal contour.
Okay.
So if you so whatever assessment we do, it's a wrong thing. So you have to wait for in the pregnancy as well as the lactation.
Lactation, how many months?
6
sir?
months we
6
wait.
months.
6
After
months.
6 months, it's
Yeah,
safe
6
to do.
months it is better. But what I do, I ask the mother whether they have stopped lactating or not. Because we cannot say 6 months, we cannot standardize for everybody.
Okay.
So the hormones, you cannot say that after 6 months hormones will be normal after 6 months. So I do whether when they stop feeding.
Okay, recently I had a patient who's lactating 9-month-old baby with
Okay.
advanced keratoconus. So should I wait or should I do C3R
See,
for that
this is
baby?
a very difficult clinical situation we find because they come in those period only. What would have happened is during this pregnancy and their keratoconus would have progressed very fast because they don't
Okay.
come in early phases because the keratoconus is not affecting much to their vision. And during pregnancy, because of change in this hormone, the keratoconus would have progressed. So we have to wait. There is no other way.
Okay. So once she stops lactation, like how long do you have to wait to reassess before deciding?
No, whenever they stop feeding, I'll do. Usually, nowadays they feed around 8 months, 1 year, maximum 1 year. So
No,
after
she
one,
wants to continue till
yeah.
2 years. That is the problem. This patient I had. Okay, so after 2 years, if she stops lactating, and then you can
Yeah, you can do
reassess.
it. You can choose your protocol depending on the thickness.
Thank you, sir.
I just want to make a quick comment in this regard. So basically, CXL, the studies performed earlier were never based, any pregnant or lactating mothers were always excluded from the study. So any procedure, what we are going to do is has got some benefits and risks. Benefits we are aware about it, but risk we are not aware. So therefore, actually, there is no per se why it is contraindicated, but definitely we don't know what are the risks involved in that, and therefore it's a contraindication. So it is all, we have to always weigh up benefits and risk before proceeding anything for that.
Thank you, sir.
Just a quick comment I want to make. Whenever you plan for a C3R, after starting the machine, always calibrate the machine. So because it comes with a small calibrator, and you have to check that it is giving a proper power which is intended. Suppose you set the machine on 3 milliwatt per 3 milliwatt, and at particular distance it's emitting the same amount of power. That is very important before starting C3 in a patient. So every time when you start a machine, do calibrate the machine before starting it.
So that's a very important point he pointed out. Every session you have to calibrate the C3R machine, because most of us we use our Indian machines, and I'm sorry to say that sometimes they won't work, because they sometimes deliver more energy, sometimes they deliver less energy. So you have to calibrate and do. Yes.
Sir, have you noticed more sterile infiltrates and accelerated cross-linking compared to any kind of sterile infiltrates? Have you noticed more so
definitely.
in accelerated?
See, sterile infiltrates have been, we have noticed those things, and one of the most common risk factor is untreated ocular surface allergy. So the patients who have got the active VKC or atopy, these kind of patients do have a risk for developing sterile infiltrates. So definitely we need to treat therefore surface allergy first and then proceed for a C3R rather than going directly for C3R.
So one more. For extra procedure, what is the time of pre-soaking, and what's the power and time that you do for extra procedure? Pre-soaking time.
Extra procedure depends on refractive error. So
Trans PRK with CXL.
PRK with extra you're telling?
Yeah.
So the aim is you cannot ablate more than 50 microns. So whatever refractive error is there, either it is a cylinder or spherical, that has to fit into 50 microns.
The pre-soaking with riboflavin, when I'm asking, sir. Pre-soaking with riboflavin, how long should we soak with riboflavin before starting the UV radiation?
In a
In
standard
the extra procedure. With the trans PRK, if I'm doing C3R, what is the pre-soaking time? Because we've already, ablated the Bowmans. So you don't need
no, see, when you deepithelize, in extra procedure you are telling?
yeah, extra procedure. How long should we put riboflavin and wait before starting the UV?
See, you can use the Dresden protocol as well as I'm sorry, it is regularly. So every 10 minutes for 30 minutes before going inside, and inside when you are doing a C3R, every 5 minutes. It is not exactly every 5 minutes. You have to see the intensity of the light.
Okay.
The intensity of the light. So it will be very bright when exact the irradiation is coming. So what happens, if you see the intensity of the light is little bit decreasing, that means the riboflavin is not there on the cornea. So even though the UVA is coming down, the riboflavin is not there. That time again you have to put it. So that's why they have made it every 5 minutes one drop. And also you have to cover something surrounding the limbus, so that riboflavin will not soak out, and also it will cover the epithelium. Limbal stem cells.
Okay.
Hello, sir. I have one patient. I noticed progression after 4 months of C3R. How to go about next?
See, there are some reports like that. See, there are two things are there. One is whether the progression. Two things we can blame is whether we have done a C3R in a correct manner. One thing. Second thing, the innate nature of that cornea. The innate nature of that cornea is not accepting the C3Rs. So there is whatever the weakness of the cornea is there, it is too much. That two things we can think of. So see, if you have done a C3R following the standard protocol, whichever you have done, Dresden or accelerated, if still there is a progression, that means the cornea there is an innate problem in the cornea. So these corneas, even if you do re-C3R, they are not going to benefit. So you have to think of some other procedure.
Okay. So scleral contact lens, can we?
Scleral contact lens?
Yes, sir. To prevent.
So scleral contact lens can be given. There is no, because for visual rehabilitation we can give RGP lenses and all scleral contact lenses. The basic thing is the C3R has to be stabilized.
So repeat C3R is not
No,
need to go.
many reports are there. Once the C3R fails, usually the repeat C3R doesn't work.
Okay, sir. Thank you.
Just wanted to know what was the age of that patient?
27, sir.
27.
Yes.
That's quite. I think that you should go for the protocol. What protocol was used? Was it a EP protocol or was
AP
it
off. AP off.
EP off?
Yes.
Okay. So that's quite rare. By the way, failure of C3R we can determine only at the end of 1 year. So it's too early to catch on. Like, at what basis you are saying that it's progressed? Being a Pachy or like what?
Being in Pachy and K-Max also, sir.
K-Max has.
But patient vision wise and all, he is not telling anything.
You are telling Pachy is reduced.
Yes, sir.
Topography?
Topography. Pachy is reduced and K-Max is also increased.
Actually, this is a natural phenomenon. If there is only Pachy is reduced, that is a natural phenomenon. What happens? These corneal collagens become more compact. More compact, and naturally the corneal thickness will reduce for at least for 2 years. The studies have shown that after the C3R, the corneal thickness will reduce. Slowly it will regain to the, it is pre-operative level after 2 years.
Okay.
So you have done some studies also, it also shows like that. Okay, and if it is,
K-Max was also increased, sir. Around K-Max was increased around
K-Max
1.
is also increased.
Yes.
Okay. And I think you have to wait for some more time.
Some more time.
Really you have to confirm it whether it is progression or just it is a post of corneal, reduced corneal thickness.
Okay, sir.
See, that's why I mentioned in my presentation also that you need to take care of two things. One thing is, like I said, if they are using contact lenses after the cross-linking, because sometimes warpage can also cause that, okay? The second thing is, what happens in these very advanced keratoconus is there can be a hyperplasia also of the epithelium. So epithelial mapping is very, very important. So following the cross-linking, when you look at the progression, the first thing you need to do is epithelial mapping.
Okay, sir.
Because pseudo-progression is very common in very, very high K values. So you need to ensure that and then you do the cross-linking. Because pseudo-progression is very, very common. So that is something that you also need to keep in mind.
Okay, sir. Thank you, sir.
So thank you all for being with us. Thank you.
The next team has